little bit and not as fast as I've been talking in previous sessions. And I'll try to, based on the questions that were provided, that we have time to dig in a little bit more on these questions, okay? So what I like to do now is to transition to our next panel. And so with this panel, we're going to be talking about this medical distrust issues in COVID-19. We talked a little bit about these issues and this issue in previous sessions, but I think that issue is really, really important to why we maybe have some of the disparities in morbidity and mortality. And so when you think about the impact of medical distrust, as other panels have said, and for the other panels, we have historical reasons why for that why we have, this medical distrust, and some of that may have been, has gotten worse with this situation with COVID-19. But today we have two speakers that are gonna really walk us through this. So we have Dr. Patricia Miranda Hartson with Wayne State Health Disparities Program at Wayne State University. And we have Dr. Roland Thorpe Jr., Director of Program for Research in Men's Health, Hopkins Center for Health Disparity Solutions at Johns Hopkins University. And let me just give a little bit of background on our speakers. Second. So Dr. Patricia Miranda Hartson is the daughter of former farm workers and sharecroppers. She's a health equity policy scholar with over 18 years of experience with community-based participatory methods and expertise in the measurement of population-based health disparities. Her work looks at the intersectionality of gender, race, class, and immigration, evaluating health disparities. She joined Wayne State in August 2020 as tenured associate professor of public health. She's formerly Dr. Miranda was tenured associate professor of health policy administration at Penn State University. And our second speaker is Dr. Roland J. Thorpe Jr. He holds joint appointments in medicine and in neurology at the Johns Hopkins University School of Medicine. He is associate professor of health, behavior, and society at Hopkins and Bloomberg School of Public Health. He serves again as the director for the program for research on men's health at Hopkins Center for Health Disparity Solutions. His research focuses on racial and socioeconomic health disparities, particularly among U.S. men. And he is a proud graduate of Historically Black College University. He's a Florida A&M Rattler, but he's not the first A&M. The first A&M role is Alabama A&M, just to let you know. He's also been
I'm going to even deal with that right now. This isn't the time. We'll go back to dates.
Okay, he's also a member of the Advisory Committee on Minority Health at the U.S. Department of Health and Human Services. You know I'm just messing with you, man.
I know.
So the first question, again, we have two speakers. So as I said, we can dig in a little bit more to these questions. But unfortunately, there have been numerous examples of abuse of people of color, people with disabilities in indigenous communities at the hands of the medical and public health research enterprise. You can think about Henrietta Lacks, the hepatitis studies at Willowbrook State School, misuse of blood samples from the Havasupai people. We have Tuskegee, of course. How do we see these issues, this mistrust of medicine and this mistrust of science manifesting itself with this COVID-19 pandemic? Let me go to Dr. Thorpe first.
So first of all, Dr. Wilson, thank you for inviting me. I'm honored to be here with Dr. Miranda Hartson. I think we're in an incredibly difficult time, as you know, in America. And I think the issue of conducting with this rapid notion of moving things really fast, with trying to get into communities and help the communities of color and get them the resources that they need. I just want to make certain that COVID-19, the issues that we had before COVID-19 are still the same issues. Now they're just exacerbated, and I believe they'll be sped up because there's this rush to get things in the community. But I think a couple things I think need to occur. I think we need to make sure this can work if the people that are going into the communities already have relationships with the communities, right? If you don't have these relationships with the communities and there's not trust there, then it turns into this, well, a parachute research, going in, getting information, getting out, and never leaving anything behind. I also think that, you know, with this type of research to dismantle these abuses and things, I think we need to focus more on these community participatory based research methods, which within those methods, there's trust and relationship building. And it seems to me, my understanding and my experience that many times people don't want to engage in those things. They just want to go immediately and bypass the trust issues and not even think clearly through what implications it has when you go into communities of color and impact you may have by taking them and abusing them and getting information and never developing a relationship and giving back to that community. And I'll stop right there.
So, Dr. Miranda Hartsuff, can you chime in on that? Like, how is this mistrust? How you sense mistrust manifest itself either in your work at Wayne State, what you seen, in Detroit, you know, as a hot spot for COVID, what you seen in the state of Michigan? What have you been seeing, please? Oh, you're on mute.
I see it. Thank you. So I am newer to Wayne State, but not to Michigan. And certainly, I think if we start with, so I think the most recent Gallup poll showed more than a third of Americans wouldn't go for the COVID-19 vaccine, right? If it were ready today. And then more than 40% of non-white Americans were listed as saying they wouldn't get the vaccine. And so I think we're seeing that traditional underrepresentation there that stems from that mistrust replicating itself throughout this process. I think we're going to see it become especially problematic when we're moving forward with vaccine trials. In Detroit, certainly you've seen similar expressions. We are hoping that, as Dr. Thorpe mentioned, the necessity of community-based work and existing engagement in the communities, we're hoping that those relationships continue going forward in this process as we go forward, because historically these same communities haven't received flu vaccinations. And so then you continue to see disproportionate work loss in them. And so that's a real fear that that's what's going to continue this year, and especially in the next coming months for these populations. And so I think it's just really key to have community engagement throughout this process, encouragement from individuals from within the community, walking communities through what good science is, what can be trusted. I think those are going to be all the relationships that we'll see are really important going forward here.
So let's dig in on that a little bit. So you're both talking about relationships. It's the relationships that communities have with science. Yan, I'm gonna ask you to do something for me. Put the blog into the specific blog about scientific racism into the chat. Also add the blog about we don't need warp speed, we need justice. Add those blogs into the chat, please. They help us fill out some of this discussion. So y'all highlight a couple points that we've talked about. We're talking about these issues all the time. Relationships are really important just in general. You know, how do you build trust when trust has been broken? How do you build trust, as Roland said, things have been extracted in helicopter? How do you build trust when promises from research have been broken? I mean, so can y'all kind of dig into that? Because, you know, Tuskegee is not the only example. We have multiple examples. We can go back to the father gynecology.
Yes.
Enslaved, African women, right?
Mm-hmm.
You can go to, I just saw an article a couple months ago, the first heart surgery, I think, successful heart surgery in the state of Virginia. It was for a white male. It was from a black man who was in a car accident and the next day they took his heart. Okay, so can y'all dig more into that, into the why we have the mistrust? I mean, it's deep, y'all. So,
Well,
I'm gonna stop. Go ahead.
So what we have the mistrust because of the examples that you shared with us, and the way to overcome the mistrust, I think, is to develop you. It's important. We did a study a couple of years, about 10 years ago, in the community, in Southwest Baltimore. Myself and Dr. Thomas Levis, this Exploring Health Disparities and Integrated Community Study, and we went into the community and we met with the community leaders. And we told them what we wanted to do. And we developed a relationship with them. Then we had a town hall meeting, invited everybody to the community and shared with them what we wanted to do, why we wanted to do. We educated them on what we were planning to do, right? And then we asked them, is there anything that you want, right? So we engaged them, and we also have them share their ideas, and we married that into we put, to the extent possible, the as much as we could with the allocation of resources we had at the time into our study, and we made them feel like they were part of it, as opposed to Dr. Wilson. Many times they're not into the city. They don't even have a say. You just say, you're gonna run up in there, you say, we're gonna do this, is what we plan to do in the town hall meeting, and we're gonna be knocking on your doors, or we're gonna be getting in contact with you anyway, whichever way we said we were gonna do it, which is, I think, it's not the way to do it. I think you have to engage them, right? And you have to share with them what's going on, because oftentimes what happens in the communities of colors, at least the ones that I've worked with, is that if they're not informed, then all well-intentioned ideas could go bad fast, because then what you have is that what they believe what your mission is may not be the same as what you think is going on. So you have this disconnect. So I always feel that you have to have this very open, transparent communication. And not only when they get involved, they need to be involved every step of the way, so that they can see what is being done. And what you need to do is you need to leave something in that community. I'm a big proponent of leaving something in the community, and I think you have to build this trust. And it isn't done overnight. This isn't something that's very easy to do. And a lot of times, I think oftentimes in science, as academicians know, what happens is most of us are on clocks for promotion, and you have to go in, and they want you to go in and do all these things, and that has to be, you have to find a common compromise, because that typically disrupts the relationship as well, right? And the community don't need no journal article. They probably can't get even access to the journal article.
Say it, bro.
They can't get no access to the journal. And then, so what we need to do is we need to leave something tangible to them that they can actually use. Or what we need to be doing, and then I'll let Dr. Hartsuff talk. What we need to be doing is we need to be developing an evidence base, so that Dr. Hartsuff can think about putting these policies in place to improve the environment and the community, or whatever it is you're trying to do to improve that community or those individuals. That's what I think we need to do, but it has to be done in a trustworthy and step-by-step fashion.
Yes, thank you. Dr. Miranda Hartsuff, go ahead.
Yeah, so I think when you're talking about, so you can talk about our history of mistrust, but we also need to address the present day mistrust and last week's whistleblower, right? And the continued violation of women's bodies while they are being held, right? And so it's not just a history of mistrust, it's a reality of mistrust that's in our political system. And so when we're going forward with providers, so first of all, we have to address the structural racism that withholds basic human rights from all people. Secondly, providers have to demonstrate that they are partners in this endeavor. So it's essential. I don't know how much people have been talking about trauma to this point, but it's essential for providers to use a trauma-informed approach, because that's what our communities have faced historically. And without making those addressing those issues. Our communities might not even benefit from those services without using that type of approach. There have been a number of principles implemented previously. They're actually quite relevant for providers to instill moving forward. So recognizing the impact of violence and victimization on development and coping strategies, identifying recovery from trauma as a primary goal. This alone is going to be a huge lift for our mental health services, our primary care services, our schools, our social workers, for everyone really. Trying to work towards employing an empowerment model with goals that are mutual and collaboratively established. So again, we're talking about a lot about that importance of partnership. And unfortunately, too much of health disparities work has come from this deficit model. But so we really need to highlight adaptations over symptoms, and then resilience over pathology to the extent that we're able within our communities, so that everyone can really rise up in this time to address these issues that need to be addressed.
So let me repeat what you just said. You speak in my language. Now, some of it, not my research language, but my lived experience language. As I like to say, many of you are on this call, I've been Black my whole life. Y'all can tell, right? 45 years, okay? Been dealing with racism my whole life. It's trauma seeing Black men murdered. Charles Barkley said a couple of weeks ago when the NBA players going to boycott, their games. It's exhausting being Black. It's traumatic seeing Black folks murdered. But what you're saying, Dr. Webb Hooper, I mean, not Dr. Webb, I'm sorry, Dr. Hartson, sorry. Miranda Hartson, you're Hartsuff, I'm sorry. I'm just talking too fast. Miranda Hartson. You're talking about trauma. So you're talking about trauma with COVID-19, but it's trauma we're already dealing with that we weren't recognizing. Trauma of gun violence, we talk about that. Trauma of police brutality, we talk about that. The trauma of criminalization of our kids, right? The trauma of living in communities that are being dumped on. It's so much layering of trauma that hasn't been addressed. So that's a powerful point that you're making. Another powerful point you're making, we have to focus on empowerment. And I'd like to say, Dr. Miranda, it's not empowerment with an EM, empowerment with an IN. How can you help people connect to the power they already have? Actualize that power, right? That's a very important point. How can we use science to empower? How can we use science to inspire? How can we use science for social justice? That should be at the core of what we're doing with our research. And your third point, get off of deficits. Our research is so biomedical, it's reductionist. That's a deficit approach. Talk about assets, talk about strengths, talk about our power, talk about our spirit, talk about hope and love. That message, you just hit up on three really, really important points. But I want to stop talking here because I'm getting excited and I can't even talk. I'm stammering, but let me slow down a little bit. So this relationship building piece and partnership piece, and those things are really, really important. And we have another question that just to kind of, unless Dr. Thorpe, you want to chime in real quick when we go to the next question?
Well, yeah, I just want to say one thing before we move forward. And as I looked at the questions, I think we've already touched on some of them. But I wanted to just to make the point that Dr. Hartsuff actually made, and you reiterated. It's so very important for us to present, talk, write, from an asset base, because if we don't, we're no longer, all we're doing is re-stigmatizing and re-traumatizing what has already been done, right? Exactly. And it exacts a toll on you. I have to tell you, Dr. Wilson, I have taken a whole, just give me just 1 minute to share this.
Yes, sir. Go ahead.
1 minute.
Yes,
I've taken a different approach in how I write my science. Real quick example, I was writing about Black men and depressive symptoms, and in the review process, they wanted me, I said something about we need more information regarding so we can understand stressors and how they impact depression on Black men. The reviewer wanted me to write something similar to, and I'm paraphrasing, something similar, that we need to go in jails to do this type of work. So to me, that suggests that that's the only place we can find Black men that are depressed. And I refused to write it. Of course, I didn't get the paper published in that journal. It's a high impact journal. I didn't get it published, but it was okay because I've come to the point where I'm not going to do that. I know, when you know better, you need to do better. And I
Sure.
know better, and I'm not gonna do it, and I'll never submit anything else there again. And this is during COVID, where you see all these things already heightened. Everybody's awareness is heightened, although I believe their awareness is always heightened before. They just was ignoring it, and we're not allowing it to be ignored this time.
No, I think you made a really important point, and this is a point. Again, this is a conversation, y'all. So I'm going to talk a little bit more because it's two speakers, but also this is really important. You just call it, I call it pain pimping science. You just talked about pain pimping science. Too much science that we're funding is pain pimping science. We are making money. This is the thing, y'all. Many folks will use this language. We're hustlers for change. A lot of folks in academia are hustlers for change in their pocket, not hustlers for change for their people. How can you use science for change for the people and not be extractive, not be guinea pig science, not be colonial science? And that's why that blog we wrote, we don't need warp speed, we need justice. We need different kinds of science being done by different kinds of people. We need science being done by more folks of color. If you look at the Operation Warp Speed leadership, not a single person of color in the main leadership. Y'all can go look, go to the blog. I did the work just to make sure I was correct on that fact, okay? Morehouse, and I didn't mention this in the previous panel with Dr. Webb Hooper, Morehouse received $40 million to be that coordinating center, right? Historical Black colleges is important. Why is it important? We need more folks of color doing the science, right? People who come from the communities doing the science, who have the cultural lens, and somebody mentioned competency, the competency to understand why we're doing this science. We're not doing this science to study folks. We're doing this science to empower folks, right? As Dr. Miranda just said, empower folks. Asset-based, as Dr. Thorpe just said, right? I mean, these are really important points. So what I'm saying is, and y'all are saying this, even under COVID-19, we dealing with this trauma. We have to do better science. We have to do more diverse science, right? More people, diversity, but more inclusive science, and more science that's about hope and love. I mean, I know that's kind of weird to say that, but there's a term called salutogenesis. Some of y'all heard me say this. I'm all on this soapbox, Dr. Miranda Hartsuff, what you said before. Salutogenesis. How do you promote health and wellness and well-being across all dimensions of the environment? It's positive. It's asset-based, built environment, natural environment, social environment, economic environment, right? Political environment, spiritual environment. That's the kind of science that we need, y'all. That's the kind of science we need NIH to be funding. That's the kind of science we need all our federal agencies to be funding. Not what's wrong with you, but what's right with you. Even under COVID, what's right with us and how we can build around that. So let me be quiet, so I'm talking too much. Y'all want to respond to that? If not, I'll go to the next question.
Well, I just want to respond by saying, that Dr. James Jackson, who recently passed, I read the beautifully written article in the New York Times that was written about him. And back in 1979, when he did the National Study of Black Americans, he mentioned something to the effect what you just said. He said, most of the science is based off problem focus, right? What is wrong with X, Y, Z? But he reframed it and said, and I'm paraphrasing, in spite of all these structural impediments, why do Blacks do well? And that's how he has framed his research over all the years, And so I think when we think about it from a community standpoint, how can we help these communities? How can we empower these communities, right? And how can we bring them with the science, right? How can we bring them and let them be a part of the scientific process? And I think that's because that's part of the empowerment as you go along, right? As opposed to the opposite approach, or one of the opposite approach to be just come in and get what we get and leave, and then we write it up in some academic journal and no one ever hears about it again.
Yeah, I just want to say real quickly, that's another important point about changing the way we do science. I am an editor-in-chief of a journel, right? I'm a new editor-in-chief of environmental justice. We got some special issues. Y'all want to go look, check them out, right? But publications is about us. If you trying to change policy, I think Omega, one of my community mentors, might be still on the line. Omega calls publications toilet paper. That is not science communication, y'all. If you want to really impact change, this is what we got to be doing. And y'all are both saying this. We got to let the people speak with their own voices. We got to be using factoids, fact sheets, right? We got to be doing infographics. We got to be doing white papers, policy briefs. We got to be doing Facebook. We got to be doing tweets. We got to be doing Instagram and TikToking. We got to be able to, you got to do your elevator speech to the policymaker. You got to do your elevator speech to the town mayor. You got to do your elevator speech. It has to be 15, 30 seconds. How do you do that verbally or written? That's science communication, y'all. What publications is not about, that's selfishness. Other kinds of science communication, that's selflessness. I just want to emphasize that point because y'all hit it on the head. This is important for COVID-19. This is important to empower folks. Getting science, rebuilding trust in science. Right? People don't trust science. Why? We keep talking about complex, like the big S in science. Science is every day. Science is pocketbook. Science is proximal. We're using science right now. I got science on my face. I just ate some science. Y'all are all wearing science. We're talking breathing science. You turn on and off science, right? That's what we need to do a better job of as scientists. And anybody could be a scientist. You know this. You don't have to be a PhD to be a scientist. So how do we use science again to empower? Dr. Hartson, I'm gonna start talking again. I want to get back to the questions. I'm sorry. This is an exciting panel for me. So this, you mentioned this issue about medical treatment before, and this is a note for the audience. We got implicit bias issues amongst providers, which could be contributed to this distrust, and also this distrust that we see with COVID-19 testing, going back to the previous session. So for an example, according to a 2017 study, Black women are 4 times more likely to experience a pregnancy-related death than white women. So Black women are dying at 4 times the rate of white women maternal deaths in childbirth. In 2020, regardless of income, that makes no sense. So what role are these implicit biases having in relationship to health outcomes and health disparities? And how is this, Dr. Miranda Hartson, how is this relating to COVID-19 disparities?
Yeah, so unfortunately, a lot of these biases, often in the form of cultural assumptions, have been to the detriment of many lives. There's just, when we're talking about additional real world applications, there's just such a tremendous power differential between providers and patients. In COVID-19, I think this power differential gets further enhanced between employers and employees. So if you just stick with me like one second, yeah, given our audience today, I just really wanted to take the opportunity to address this point by highlighting the example of one of our most vulnerable populations in this pandemic, our agricultural workers.
Absolutely.
I've done prior work examining their use of personal protective equipment or PPE for workers to protect themselves and their families. Now, prior to the epidemic, this was primarily focused on pesticides. So now that prior work has overwhelmingly demonstrated that these workers were more likely to use PPE when it was provided by their employers. So if you think about that in the context of COVID-19 and recommended PPE use, for example, masks and all the roles employers have had in keeping employees safe. But however, in the case of our agricultural workers who provide our food, right? Many people are just unaware just how seasonal migrant workers in particular are often housed in crowded camp-style housing conditions. And in fact, in July, so you may be aware we're lacking a national plan in response to this pandemic right now. But so lacking in this national plan or mandates even from the CDC, right, to protect this essential vulnerable population. We have the National Advisory Council on Migrant Health. They made 5 recommendations: uniform, federally mandated and enforceable COVID-19 testing of all workers, support for all of migrant and seasonal agricultural workers, serving health centers, the provision of safe housing and childcare, prioritizing H2A workers' health safety needs, and then still providing the basic hazard protections against pesticide exposure that still never existed. You know, we talked from the beginning about, you know, the pandemic is just building upon, you know, weaknesses of the symptoms of the system that were already present. And so you have this deficit and this power imbalance where these disparities will continue to persist, and it will come in the form of people losing their lives.
Thank you for that. Dr. Thorpe, do you want to follow up?
No, I don't have anything. As you, Dr. Hartsuff so eloquently said it, I don't have anything to follow up. I think that was a very good example and of how we failed a group of people that were already disproportionately burdened, probably by chronic conditions that underlie the COVID-19, and now the lack of protections. This is just an example of the lack of protections and structural forces, quite frankly, that are at play, that are not providing for a group of people that work for the broader America. This is the agriculture. This is food that we eat, right? They're either managing it, growing, picking it, or something, so that we can have food. So when we go in the grocery store to purchase or go to our community places to purchase, and we can't protect them.
Yeah, and just thank you for that, Dr. Hartson. Agricultural workers, I like to say that COVID-19 has made I've said this earlier, made visible the populations our policies have made invisible. And agricultural workers are populations that we have not traditionally protected. As you said, think about it from exposure science perspective. You're in overcrowded housing, right? You think about transmission rates, host susceptibility when it comes to any type of virus, right? Any bacterial virus. Potable water access, that's a huge issue for migrant workers, whether it be, you know, those who are working, who are picking fruits and vegetables, who've been exposed to pesticides, those who work in concentrated animal feeding operations, and also, as Dr. Haney mentioned, you have a over representation of immigrant Latinx Caribbean folks who are working in meatpacking facilities in various parts of the country. So we were not protecting them in advance of COVID-19, whether it be we as the U.S. people who get that food, we being the FDA, we being OSHA, we being EPA, we being USDA. Okay, all those federal agencies play some role in what happens with our agricultural workers. So that's a very powerful point of the population to focus on. And I think what it says is, you know, and y'all are getting at, you know, the themes across these panels, structural issues. We have to address them, and these groups are just targets, easy targets, because of our policies and racism and structural inequalities, easy targets for COVID-19. So I want to go to this next question, and we lost one of our panelists who had a family emergency. So I want to talk about, you know, healthcare access issues, and maybe we can kind of end here before we take Q&A, if y'all fine with that. You know, so what are some of these solutions when it comes to mistreatment, mistrust, and healthcare access during this pandemic? So we've already mentioned access approach. We mentioned participatory research. We mentioned more diversity in scientists. We mentioned empowerment. You know, so and I just want to highlight before y'all respond, Dr. Stephen Thomas, who's done work in this area. We talk about, you know, how do you engage, you know, frontline, fence line communities? How do you engage people where they are? You got to engage those social and cultural assets. So, and you know, Dr. Thomas's work has been engaging barbershops and beauty salons. So as part of the solutions, can you kind of first answer, you know, what are some of those cultural and social assets, community assets, we need to be engaging more? We need to be activating more in the fight against COVID-19, but also in the fight for social justice and public health. And I will go with Dr. Maybe go with Dr. Thorpe first.
Okay, so you've mentioned ones, and I was going to mention, I'm glad you mentioned Dr. Stephen Thomas's outstanding work around the barbershops, because that's what I was going to bring up. Another place I think that I haven't seen a lot during COVID-19, is the role of the church, right? And I think the role of the church, and I say church, not faith-based institution. I say church because as African Americans, when at least when I was growing up in Georgia, it was all, and it still is in Georgia, church, not faith-based institution. And that's a place where historically for African Americans, when you've seen these justice, these marches going on with Martin Luther King Jr., they were many of them were congregating, taking places at churches and basements of churches to organize. So the church has been a pillar for African Americans, and I like to see a potential solution is to use the church, because by nature they've had with this justice approach, as well as a really strong cultural stronghold for African Americans. That I can't speak about any other churches because I don't know about the other churches. Mine was focused on the Black church, the African American church. But I do think the church is another institution whereby could provide some potential solutions, particularly around organizing and galvanizing a group of people. In fact, when you think about, a lot of times when you think about doing research in many communities, you seek out the part of one or two, if you go say who are our key stakeholders, 9 times out of 10, your first, one of the top 3 people is probably going to be someone that's affiliated or associated with a church, because they're usually a cornerstone for many of our communities. So I think the church is another place where we can certainly start to think about addressing solutions, because the churches have always been right on the front lines, fighting for all justice issues ever since I've been alive.
So thank you for that. So just to chime in real quick. So, we talk about this one-stop shop of services, right? Mental health services, I think y'all mentioned that, social services, economic services, workforce development, child development services. Churches played a role in that space. So churches should have an elevated role as it relates to responding to COVID-19. I would say there's been some conflicting messages coming out of some of our churches, as you've seen, because of religious liberties and this kind of religious liberties versus the science argument for protecting community and yourself against COVID-19. So there's been some tension and conflict there. So I think the education point that y'all brought up before, we have to educate our pastors and ministers, we have priests, priestesses, educate them in how science and religion are not necessarily on the opposing ends of this, and how they can work more collaboratively together, right? I think that's important. And then going back to before with Dr. Stephen Thomas, how the barbershop can be a one-stop shop, how beauty salons can be a one-stop shop, how that market, a lot of our immigrant brothers and sisters, think those who come from recent immigrants from Africa, immigrants from Central South America, Caribbean, the stores, those stores are also great places where social and economic capital being built. So how can we leverage those type of small businesses as also a way to be frontline purveyors of information about COVID-19, frontlines purveyors of information about public health issues, and also they can be facilitators when it comes to building trust between the public health community, healthcare community, those are vaccines, and building trust with the local residents. So I want to now get past the mic to Dr. Miranda Hartson.
Yeah, thanks. So I think we still need a richer understanding of the health patterns that we're observing. So we need to shift our focus away from individual level cultural explanations to the perspectives that provide broader, more in-depth, analyses of racism as that structural factor, but that it intersects with all the other dimensions of inequality that our communities are facing. So you mentioned Black women and birth outcomes, right? So gender and class, and this all impacts outcomes. And so we just need to still make this shift, because otherwise we're placing the onus of culture on the individual, and that's going to lead to individual-centered interventions and behaviors. This policy focus on, individual responsibility, and those just haven't been effective. So we just really need to shift over and see how processes, discrimination, residential segregation, and policies affect health outcomes. Right. So there's just too many othering practices that are still out there, and ultimately we'll really need to think about all of our policies, our social policies, as health policies, and how they all affect our health. It's just too imperative.
Yeah, no, that's a really important point. Ms. Curtis from the previous panel talked about health and all policies, and that she's part of the Prince County Healthcare Coalition. Mm-hmm. And she also talked about the equity lens too. So you're right on. We have to look more upstream and not individual level. We have to move away from otherizing, and so otherizing of people. So that's really important point about otherizing. We've otherized folks through our housing policies, our food policies, right? Yes. Healthcare policies, and we've otherized folks in many ways. We talk about how the negative way we use science to look what's wrong with you. We've also otherized people that way through science, right? So I think that's a really, really important point. It gets back to your point, and thank you again for making a point, because you talk about empowerment. My students know I talk about empowerment all the time. So I appreciate you're talking about more empowering policies, empowerment science is really important. So the last word here, I want to give y'all, a few seconds just to close. So I will go back to Dr. Miranda. You want to close out? Like, what are your closing comments on this topic of medical distrust and solutions around COVID-19 pandemic?
Vote.
Vote. That's a great last word. You have to say one word, but that's a powerful one word to leave with. It's the same one word that Mustafa Ali and Dr. Adrian Hollis mentioned in the first opening panel. Vote like our lives depend on it. Dr. Thorpe?
Yeah, I want to do two things. First, I want to Dr. Miranda Hartson, I want to apologize to you. I didn't recognize your name was hyphenated. And so I just want to apologize. I got glasses on, I still can't see. But then I finally saw the hyphen, and I know I have been calling you out of your name, and I want to apologize because I wasn't raised that way. So please accept my apologies for one. Secondly, the closing thing is I think we're going to have to just quickly employ our political determinants of health so that we can combat these social ills that we have. And we can't study it and talk about and better in the community without thinking about ways in which these structural factors hold us at bay. And so we have to start thinking about how to dismantle those, because the individual choices are constrained by their broader social structures. And so we have to think about that in that way. And thinking about the political determinants of how to dismantle these structural factors, namely structural racism, is going to be important moving forward.
No, very, very powerful closing points. One word: vote. Political determinants. Make sure when you're voting, vote for people who represent your interests, and hold them accountable. I like to end here. No politician goes to politician school. It's certain when we vote, that's the minimum that you do in civic engagement. You got to hold them accountable. You don't wait 4 years to evaluate them. You don't evaluate your students after 4 years. You don't evaluate your staff once every 4 years. So why we evaluate politicians when they're running again? When they get in there, you should have a 1 month plan. What are you doing after 1 month in office? You should follow with them and be whispering in their ear in the same way lobbyists are whispering in their ears, in the same way developers are whispering in their ears, in the same way people who were basically doing speculation of death of COVID-19 are making money off this economic crisis, this mental health crisis, this health crisis, are whispered in their ears. Hold them accountable. So once you vote and you have your triple mask on and your face shield on, you get out there in that line, also put the same stuff back on and knock on their doors and make sure they have the agenda and plan that they're doing what you want them to do. Because if not, we're going to be having this conversation again with the next pandemic, wondering why we didn't do what we're supposed to do. So I'm going to be quiet because I'm getting a little bit excited. Thank our panelists for this great panel. It was a great fireside chat or sunny day chat, whatever you want to call it. And we're going to take a break. And our next panel, the closing panel for the day, is going to start at 2 o'clock. So thank you, Dr. Miranda-Hartsuff, and thank you, Dr. Thorpe. Appreciate your time.
Bye-bye. Thank you.
Bye-bye.